So while the panelists are getting seated, I want to get us going here. So this is the panel on community perspectives on the future of community engaged research and action. My name is Tung Nguyen, and I'm a co-leader of the community engagement program of the CTSI. And we'll start with this audience participation poll. What are most of the people and communities you care for or work with are feeling right now about the reductions in research support? Here are the choices. They haven't heard about it. They support the cuts. They care about it, but it's not as important as other issues. They feel it's important, but it's something they feel they cannot fix. They feel it's important, and they're ready to do something about it. You only get to choose one. I'm sure you may want to choose more, but... Okay, so two of them are kind of competing for the lead. They care, but it's not something they can fix. And they care, but it's not as important as other things. Okay, well, thank you for your input. Before I introduce our panelists, I want to provide a few words to provide the context for this discussion. So those of us doing community engaged health research, I presume all of us, have argued that health research without community engagement has very limited relevance and impact on our society. And the poll this morning that we did, I think, confirmed that. And as Vanessa said, the NIH created a CTSI funding mechanism, and in part, that was, about 20-some years ago. It was in part to address the problem that it took a long time for scientific discoveries to become standard of practice in our communities. And community engaged research is an integral to that approach. The COVID-19 pandemic response, I just wanted to summarize how amazing that was. We had a decade of investment in mRNA vaccine research. We had 1 year to come up with an effective vaccine and prove that it was efficacious. And then within a year and a half of that, we had 80% of the population vaccinated. To me, that was an unprecedented display of the impact of our science and scientists. And yet, following that, what do we have? We have distrust, we have mistrust, and we have anti-science policies. A Pew Research Institute survey in October of last year showed that 23% of Americans did not have confidence in scientists to act in the best interest of the public. A third did not think that scientists were focused on solving real-world problems. And a third did not think that scientists were honest. Less than half thought that scientists were good communicators. Now, I teach community engaged research, and what are some of the topics that we teach? Distrust, trustworthiness, trust building, how to communicate science better to communities, academic and community coalition for policy change. The point being that community engaged research is built for these challenging times, and that our health and population and our communities need this work more than ever. Now that's the positive, affirmative, asset-based framing. I was ready to roll with that. And then yesterday, the Supreme Court ruled that it was okay for law enforcement to pull people over for the way they look and for the words they speak. Now we know that racial profiling has been a thing, but it is a very significant moment when the highest court in the land say, it is okay. I think it's fair to say that science and research were below, as that poll has shown, on the list of priorities for people living in a system that makes them fearful of going to school, of going to work, and to places of worship, and anything else. A legitimate question could be asked that, rather than just some of the questions we're asking today, what academic researchers and what community engagement can be done to improve the lives of our people today, not 5 years from now? So with that, I'd like to introduce our panelists who are champions of this work from the community side. Their bios are in your packet. I'm going to be very brief. So we have Roberto Hernandez, who is a native and resident of San Francisco's Mission District. He is Chief Executive Officer and founder of MECA, the Mission Economic Cultural Association, and the CEO of also CANA, and I'm going to not say this right, Cultura y Arte Nativa de las Americas. He is also, significantly, the principal investigator of an NIH-funded grant called Somos Esenciales, Community Revitalization and Health through Latino Arts and Entrepreneurship. Diptee Ojha is a research executive with over 20 years of leading patient-centered and equity-focused initiatives across multiple health systems. She's director of the Research, Implementation, Science, and Evaluation for the Community Health Center Network, which is a network of 8 federally qualified health centers. And Shanell Williams is a passionate and dedicated public advocate, nonprofit leader, and community organizer. She's currently the executive director for Rafiki Coalition for Health and Wellness, and prior to that, she was director of community engagement for the Preterm Birth Initiative at UCSF. And just by the way, she was also past president of the City College of San Francisco Board of Trustees. So welcome all. I want to start. So I'm going to start with just a general question for all of you, which is to describe what you want us to know about yourself and your organization. We'll start with Shanell and going down.
Thank you so much, Tung, and it's so good to be back and just seeing everyone. So I'll start with Rafiki because we turn 40 years old next year. 40 years, 4 decades. That's a huge, huge feat. Rafiki Coalition for Health and Wellness, we're based primarily in the Bayview Hunters Point area here in San Francisco, but we serve all of San Francisco. We've been primarily Black-led, which is also amazing. I'm an SF native. I know the history of Black displacement in the city. To have an institution like Rafiki still leading, it's an amazing thing. We have 4 clinics. We have a mental health clinic. We have a behavioral health clinic. We're in the high schools. We're at Balboa High providing mental health services. And we have our very beloved complementary medicine clinic as well. And throughout the year, we do a ton of health and wellness promotion programming. We do a lot of cultural enrichment activities. I mean, everything from movement, yoga, nutrition. We really want communities to come in and feel like they're part of a village. And we've been fortunate enough to also partner for 20 years with UCSF, doing community-based participatory research and also have our hands in some policy work because, as you know, we have to do it all to protect our communities. It's not just the direct services, it's really combined with the advocacy and the research where we get that secret sauce. And for myself, like I said, I'm an SF native and I've been in this work about 25 years, doing community-based work in many different areas, everything from criminal justice reform, supporting young women and girls, just the whole gamut, and then of course education. Spent a lot of time at City College of San Francisco, as a trustee and then board president. So really, really love this work and excited for the conversation, so I'll pass it along.
I don't know how to follow that. But so thrilled to be here. Thank you so much, Tung. And I'm Diptee Ojha. I'm the Director for Research, Implementation, Science, and Evaluation, or better called RISE, at Community Health Center Network. We are a network of 8 federally qualified health centers serving primarily in Alameda County, but also neighboring counties. And we have over 130 locations across the county, as well as over 20 or somewhat 20 or so mobile clinics also. We serve primarily across all diversity of payer mix in our patient base, but 75% of our population base that we serve are Medicaid population. We have a comprehensive services of primary care, specialist, and behavioral health and dental services. And quite recently, we've started embarking on establishing our own research program within Community Health Center Network. We have a data repository of both AHR and claims data, and we hope to use that to sort of support looking into primary healthcare outcomes of communities we serve in Alameda County. I'm a dentist by training and a health services researcher, and this is fantastic to be here today.
Buenas tardes. My name is Roberto Hernandez, and thank you for having me and having us here today. I was trained at a very young age by Cesar Chavez and Dolores Huerta. I'm a native of San Francisco's Mission District, I went for a summer to go volunteer in Delano, California, and that was the beginning of life-changing for me. As I reflect back, I think that I probably would have died in the barrio from an overdose or probably gone to prison just because of the socioeconomic conditions that I grew up in. And so I'm very blessed to even be here and be alive. So I would thank my Creator today, thank God. And I always take that moment to acknowledge that. Because of Cesar and Dolores, I became an organizer, and that's what I am. You know, all these titles I get, to me, I'm an organizer. I bring people together. And one of the most important things that I learned was that people who are most affected should be the people who should be planning and making decisions. And in this context, this today, they should be part of research. And I'm not talking about giving them a $10 gift card to attend a 40-minute session to learn. I'm talking about they need to be at the table at every level. Because of that philosophy that I learned and that principle I learned at a very young age, I've been able to bring people together and make decisions together. Started the Bernal Heights Neighborhood Center after knocking on 10,000 doors and saying, what do you need? Started they call them charter schools now, but in the 80s they started a school for cholos and cholas that had been expelled and suspended from school because of the way they looked. During the pandemic, I already knew the pandemic was going to happen because I have friends who are scientists and doctors. And we started the Mission Food Hub, and we provided 9,000 families with culturally appropriate food. And it was the people that were in the lines that helped us decide what they wanted to eat. Pretty simple. And I've had the honor of working with UCSF on many projects, and during COVID we worked on, and we were the first ones that did COVID testing in 2 tracks in the Mission District, which was the highest neighborhood that was getting COVID. And we started the Latino Task Force that not only addressed the food needs, but COVID. And we learned a lot. And from there is where we began, and we'll talk about it as we engage today, right?
Thank you. So we'll start with another question. Maybe we'll start with Diptee next. What's your organization's concern in the current environment? And I'm using that word very broadly. And how, just a corollary to that is how important is research and data evaluation for your organization?
So as community health centers and with the passing of one big, beautiful bill, we know the repercussions that are going to be trickling down over the next year or so on how that's going to impact health centers and safety net in general. And specifically so when there are very specific, when you have community health centers that already run on a very lean funding scale, to have that kind of ruling and policy impact coming down. So to say that funding is of the highest of priority for our organization right now, and specifically looking into the Medicaid enrollment work requirements going from January 1st, 2026, and then looking at those coverage losses on enrollment for those individuals who are not going to be meeting the requirements for federal definition of immigration, and the loss of Medicaid enrollment on that is going to be significant on community health centers at large. So in the environment that we are operating right now, so when fiscal becomes very, very strong concern for health centers, it's about where do you find the balance of cutting out the fat. At this time, it becomes even more so important that you dig into the data to really understand like what happens. But when we look back at your poll on like what is most important and in the context of if funding is cut, what becomes more important, it's because they have other priorities that they need to fix. And so research does not rise up to the level of interest within the organization because they have other things that they need to prioritize about.
Shanell?
Yeah, it's so interesting, Diptee, because we're looking at our strategic planning process at Rafiki for the next 3 years, and we actually want to get to where you are. We thought about becoming a federally qualified health center, but now with this environment, it's like, oh, can we really do that? And we actually submitted for CalAIM, the cited grant. We're going through that process, and we need more of our federally qualified health centers, not less. And so, of course, funding. I mean, that's the big issue right now. Rafiki, we're funded primarily by governmental grants, grants through Department of Public Health. That's the majority of our funding. And yeah, we're definitely going to be seeing some cuts next fiscal year. Thankfully, we didn't get cuts this year, but we know it's coming down the pipeline, and we're preparing, just like what you said, to pivot and see if we can pivot towards major gifts, private donors, private foundations. But we still see, even in that world, folks moving away from DEI, moving away from organizations like Rafiki. We don't even know if we can say Black African American is who we primarily serve, which breaks my heart. I mean, I actually feel emotional even saying that because that's the reality that we're living in. And just now with the Supreme Court news, I mean, to have like folks roving in our communities and being able to stop folks, you know, do whatever they want essentially, and no accountability, it just creates a whole environment of uncertainty, of fear. Folks are already feeling under surveillance. They're already feeling stressed out at the local level, and now we have this additional layer of surveillance. I also want to talk about the food, because we have a community food market that we're building out in our behavioral health clinic, which is at 5000 3rd Street, 3rd and Quezada. We're really excited about that new clinic, and we want to continue to build that out to even expand to physical screenings in addition to behavioral health services such as overdose prevention and other harm reduction services. And so we have this big vision. We have a lot of dreams. We want to keep moving forward as a diverse organization, but in this climate, it's just really scary. And we want to start to think about how do we organize cross-culturally, be strategic, because folks have done this before. You mentioned Cesar Chavez and Dolores Huerta. We have greats that have done this before. So just looking to the lessons of the civil rights movement and other movement, the movement of the farm workers, to really learn from those movements and how do we get ourselves organized to resist, because it's really hard. It's really challenging right now.
I don't call it the B budget, I call it the bad budget. And if you really think about it, this is real simple. He has declared war against the people of this country and the most vulnerable. And when you look at where the money's going, it's going to ICE, it's going to the military. And that's not new to us. If you really look at the past budgets, whether it be the Democrats or the Republicans, the majority of the money goes to the military. And so we've had to be resilient, right, just to be able to survive. One of the things that we're calling for now is on all the millionaires and billionaires that live in our city, in our state, in our country to step up. You know, they have a responsibility, you know. One of the learning lessons from the pandemic was that there was a lot of cash workers out of those 9,000 families that we served at the Mission Food Hub. And it was not only the Mission, we were in the Bayview, we were in the Excelsior, we created a network. We basically took care of the east side of the city, right? And where did that money come from? It didn't come from the government. The federal government was, look how long it took him, right, back then to even acknowledge that there was a pandemic, right? The state of California wasn't ready. The city of San Francisco wasn't ready. It was the community that stepped up immediately and got things done. And so one of the things that we learned was that there was 3,000 cash workers, right, who couldn't collect unemployment because you're a cash worker. You got no retirement, you got nothing, right? Research there, real quick, right? Research that. Then we found out that, not only people couldn't buy food, they couldn't pay their rent. Now, if you live in the Mission or on the east side of the city, right, you know that we've been violently gentrified. African American community, if you look at what Lennar did, if you look at what happened in the Mission when the dot-com boom came, and then when you look at when tech came, when Twitter came, right? And you look how, that was criminal. And you had over 10,000 people that got evicted out of the Mission. Yeah, and we fought, and we saved 17,000 people from being evicted. But housing is medicine. Food is medicine. Research that. Today, we're still dealing with the impact of evictions. Some of our people went and lived on an RV, and look what they're doing now. They're criminalizing living in an RV. You got to move. You can't be on the street. So when you talk about funding to end it, right, is that I'm going to go back to the cash workers. Some of them worked for some of these billionaires, tech people. And so we got a hold of some of those millionaires and billionaires and said, hey, you need to pay the rent for that person who you don't want cleaning your house that you ain't paying now. Pay their rent. Give money so we can feed them.
Thank you. I just want to acknowledge that as difficult as things are right now, and they're about as difficult as I've ever seen them, things have been difficult for a long time for a lot of people. One of the impetus that I got into community engaged research was wanting to help our community organization diversify their funding portfolio, because we all know that community organizations just basically go year to year with their funding. And by giving them sort of another option, like being part of health research grants, for example, that just diversifies it a little bit more. We always knew that it was never going to be their number one priority. That's not their job. The question is now, it's a little bit of a crunch now, right? So both the funding on the service side is down and funding on the research side is down. And we're here at UCF, we're thinking, we got to go scramble looking for funding, and we want to do it with communities. So how do you think about it when we come to you with potential ideas? Like, how do you decide who you want to work with, given all these priorities and sort of issues that you're dealing with, which you just talked about? And sort of, how do you go about making that decision? We'll start with you, Shanell.
Okay.
And then we'll go to Roberto and then Diptee.
Yeah, it's so interesting because I've been on both sides of it, working at UCSF for almost 10 years in the research division and OBGYN RS, and then now being back in community on the ground as a, community partner working with, UCSF. Definitely, we just actually submitted, I think, recently, I think Kelly, I don't know if Kelly Taylor's here, but we tried to, Kelly, hey! We recently tried to submit a grant in partnership to Whopper Wood Johnson Foundation, and I know other researchers have come to us to partner, and I think that it really starts with the community. It really starts with the community-based organization, because we have organizational needs to be able to work in partnership with folks, and what staff are we going to pull to kind of carry that work definitely comes to mind. And then just, of course, I know Kelly, I know folks here, so I know where folks are coming from, but if I'm a community-based org that doesn't really have that background, like, how do you build that relationship? Because I was already starting with those relationships and knowing that, folks are good folks and they really respect community-based research. So yeah, I think it's really about building that relationship before you jump into that process. process, and it's going to be a scramble for all of us. But I think if we can work, with putting the community-based org out front in terms of really meeting those organizational, administrative sort of needs, I think that's really key. But I think it's going to be a difficult road ahead for all of us trying to engage in this research.
We have a strategic plan that we go through a process from ground up in everything that we do. And we evaluate it every year. And we adjust every year. If you look at the amount of people that approach us, whether it be institutions or even funders, we're really careful about who we partner with because we don't want to be used. And we've been there where we've been used. Number one. Number two is that it always has to be what I said earlier, is that the people most effective need to be involved, and that if it takes time to train them, then we train them and we pay them to get trained. Currently, we're with our NIH grant, we convinced NIH that in order for us to do the work right, there were some people that didn't know how to read and write at the level that they needed to, but we really wanted them. So we got we allocated some money for reading and writing. Some didn't have a high school diploma. We got a GED teacher, right? Some didn't know how to use a laptop, or they didn't know how to use the internet. So we've done all that. You should see them today. Oh my God! So a couple of them know more than I do on the internet, because I'm not an internet kind of guy, you know. And so it's important that when we partner with somebody, right, is that we look at the whole. Because if you don't look at the whole, then we're setting ourselves up to fail. And we've been there. We've been in partnerships where we failed, right? And then you feel bad about yourself and you don't feel like you can do this kind of work. And especially when you're talking about research, because you're talking about scientists, right? Somebody was talking about scientists earlier, right? And you talk about that level. And I had recently we were in a room with some scientists and doctors, and one of the members of our community said, "Those are smart people." And I said, "And so are you."
So I have had to learn hard and fast that in our organization is I field a lot of research request questions, obviously given my role, but the type of research that we end up partnering with sort of takes on a very organic review process internally. But the biggest question that we ask ourselves whenever we think about any research potential partnership or collaboration is, what is the problem that you're looking to solve for the health centers? That's the number one biggest question. And health centers, by design and by default, they do a million different things, and they want to solve the world's problem in the communities that they serve on. And because by doing so, they stretch too thin. And because by doing so, then they are while trying to solve the world's problem in that little community that they're serving, there's a lot of problems that they encounter on a daily basis. And that's where I come in to say, what is the problem you're trying to solve for the health centers? So at the end of the day, what is it that the health centers get in return for being part of this research partnership? What effort does it take for the health centers to be part of this research? what support they get to implement or disrupt any workflow in their clinical workflow, in their patient registration workflow, in anything. But big question is, what is the problem you're looking to solve? A classic example that I found is there's this NIH grant, that research funding that we currently have, that we try to solve the problem of systematically expanding data collection around social risk factors. That is one area that our health centers struggle, because it takes a lot of time to collect that data. It's very uncomfortable data. You cannot collect it over phone call. You cannot send my chart. They've tried it, trust me. Patients don't understand why you are asking these questions, and health centers don't have infrastructure built into their facilities to have like separate offices or time and funding to support their staff to spend 35 minutes with each patient to collect that data. And that data has to be collected systematically and periodically. So we found an opportunity through an NIH funding to actually support them, provide them extra funding to do that, create a pilot study, work with them, work with like what data elements that they're collecting, how are we trying to streamline it, how can we standardize it, how can we create some structure around the workflow. So that helps them, it creates some efficiencies. So it's that same ideation that like any research collaboration sort of like invite that comes to us, we look at it with the same lens. So that's what it is. It's the problem you're looking to solve.
Thank you. I have a question. I have a question for Roberto. So actually, we talk a lot about community engaged research. I actually think right before this year, the NIH had actually gotten farther than that. They went to community-led research. Basically, for some of the same thing that we've been talking about, like researchers have their own thing and communities have their own thing, and why not have community lead the research project? And that was the Compass grant mechanism. And Roberto, I'm happy to say that you got one of those, Somos Essentiales, right? You want to talk a little bit about like that project? How did you decide on applying for that grant? Who did you work with? And then how's it been going since you've gotten the grant?
It organically happened. I'm going to go back to the Mission Food Hub. In the pandemic, going back to the people in the lines who became part of the decision-making process of the Mission Food Hub, Paul Flores came to me and said, hey, I want to do a documentary about the Mission Food Hub. And he did, and he actually titled it after he interviewed everybody. He called it Somos Esenciales. We are essential, right? Because these were all the essential workers in the city, from janitors to hotel workers to maids, drivers. And from there, we actually partnered with UCSF, and that was the beginning of taking a core group of them and training them to do research. And so after the training, because there was just so many every day, it was like the Mission Food that we're trying to solve all the problems of the world during this crisis, and we just didn't have the capacity, right? And so this research really helped guide us, right? And one of the things that they did, a dishwasher, a cook, everybody that got trained came back, and they were trained on how to put a report together and the data and all that. And it was just a beautiful, amazing process. And to see the end result, and they made a presentation, right, to the community. And the number one issue that came up across, whether it be a child, a teenager, an adult, or an elder, was mental health. That was the number one thing that COVID impacted everybody across the board, right? And then when you break that down, right, how did it affect you? From sadness to depression to suicide, alcoholism, drug addiction, domestic violence. I mean, it was just mind-blowing for me when I was, hearing back from, our people. And then Dr. Lisa Fortuna, who at that time was with UCSF, and I want to, honor her for her pushing us to take it to another level, and we began taking it to another level. And then the opportunity came to apply for this NIH grant. And then when we got the grant, I was like, wow, that was kind of crazy, saying, that we would get a 5-year grant, right? Because most grants are 1 year, and to really begin to look at planning ahead. And so where we're at now, we're in the end of year 2, and what we did was we convinced NIH to take 30 of these essential workers, and train them to be to do research. And I insisted that the research be done by community people. So we got Visión y Compromiso, which is a statewide organization, right, to come in and do the training. And it's just been phenomenal and amazing, right? So they've learned these skill sets personally for themselves, plus how to become promotores y promotoras, and how to do research. But on top of that, what we did, we added another layer of learning, again, because mental health, right? Learning about indigenous cultural healing practices. So they've gone to sweat lodge, they've gone to acupuncture, they've gone to talking circles, drum circles, and all these different indigenous ways of healing, right? Because the other thing we learned was that there's not enough mental health workers, right?
Well, that was great, except I just wanted to ask you, what happened to the funding? What happened to the funding? You dropped the lead here.
One morning I wake up and I have an email that says your funding has been terminated immediately, right? And so we made some calls. We have a lot of friends, and 24 hours later it got reinstated.
Good for you. Well, I want to know who you call. I want to know who made the calls for you. We'll talk afterwards. Shanell, I want to follow up with that because you too have been PIs or principal investigator of many grants, including from Patient-Centered Outcomes Research Institute and from Chan Zuckerberg. Want to talk a little bit about that?
Yes, but we need to know who your friends are. I think we're going to get folks coming up to you after the panel. So I was a non-traditional principal investigator. When I first came to UCSF, I didn't have my credentials, but I was able to become a principal investigator for a PCORI grant, which is really about building capacity of moms in Fresno County, to be able to look at pregnancy outcomes in Fresno County. And so that was a whole journey. I really feel like the capacity building piece is essential on both sides, because we want to make sure that there's shared language was one of the really big key takeaways I got from being a principal investigator, non-traditional principal investigator, and then also did some capacity building work with Chan Zuckerberg, which we all know they have definitely pivoted in their approach lately. So we saw, we had a grant at Rafiki, but also had 2 grants here at UCSF, and they're not renewing the funding for our grant at Rafiki. We were really sad to hear that. Our community-based research work that we were doing with several focus groups we did with folks in community, asking what do they want from medical systems, what do they want out of the research. Really, really amazing data, and we've been sharing it out, but we would love to share that with all of you. And just really the long-term investment is key, because I feel like if we're doing this work, we're building the capacity in our community, learning these skills, amazing work that you've been doing, building their skills to be able to be community-based researchers, community scientists, like to be able to do all that work and have that discovery, and then to find out, like, where's that gonna go? Like, what's the future of all that hard work, building our community's capacity and interest in the research enterprise? And so I'm really disappointed to see that pivot because of all the hard work we did investing in community, and just wondering how do we pick that up and get creative so that we can take what we learn from that research, because that's the ultimate goal of research, is for it to come to life and for it to have an impact. And I think that's what community wants to see, like, what is gonna be the impact of the research? Like your question that you always ask, I'm gonna actually take that when we get all these emails, like, what is the benefit for Rafiki and our community, right? Because at the end of the day, and I saw this with our community advisory board here at UCSF, folks started to get frustrated over the years and years and years we were working together, like, okay, we're funding all this research, we're reviewing research, we're doing all this work. What is the outcome? You know, folks are needing food, they need support in our communities, they're in crisis, and we're doing this research, which is really, really important, but how do we translate that, right? That's why I think CTSI is so critical too, but the capacity building on both sides really key, but also what is gonna be that end goal that really impacts the community, and not having funders pivot like this, really, really key. I mean, and it's amazing you got them to keep your funding. That's amazing, amazing work. So we'd love to learn more about that.
Great. Just for you all, I got one more question, and then it's up to you. So please come up with questions. I'll start with Diptee, but I actually want all three of you to answer this question, because I'll now frame it before I ask in a minute. So everybody is scrambling now, right? Everybody's scrambling. It's just like in academia, we're entrepreneurs, but we're entrepreneurs with a 2 to 3 to 4 year time frame. Now we're down to every 6 months time frame, like 3 months, 6 months. So everybody's scrambling, and we know that time and money are like fundamental resources for building community relationship. Like, it's really bad to rush into something because you don't have enough money or enough time, and yet here is where we are, right? So this is a crucial moment, not just for everything, but in community engaged research. I like to think of it as, here's an opportunity to do something new. Everybody's trying to pivot over in UCSF. Maybe they should be pivoting to some different topic. Because a lot of time we say things like, oh, the community should drive the research question. But, you know, I do cancer screening, and I'm not doing any other study besides cancer screening study, and they come to me and talk to me about something else. It's kind of hard for me to switch over to diabetes, you know. Yet maybe that's what we should be doing, right? So what I want to ask you all to tell us, and you've already been telling us a bunch of this, is like, what are the things you want to study so that all these other people can be like, hey, maybe I'm interested in pivoting to that, or want to work with you on that. So we'll start with Diptee and the 8 health centers that you run.
So it's kind of hard to sort of put that into perspective beyond the black cloud over us, right? Like right now, it's so hard to like put your head above, to envision, to think about, oh my God, can we start looking at like really cool clinical questions and like really look at like, you know, true clinical outcomes? Can we start reporting on patient-reported outcomes and like, you know, assessing all of that, blah, blah, blah. I mean, I would love to do that. But it's, again, going back to the problem, the big question is, at the community health center level, like right now with the black cloud hanging over us, and for probably for foreseeable future, we are only thinking about like what problems are we trying to solve. So it's like, what creates process improvement? What constitutes efficiency in clinic without any sort of like impact on human capital? Sort of, how do we get more patients in the door? How do we minimize, or how do we ensure patient safety from all aspects? Like meaning, you know, data is central to it. When you are partnering with community health centers, there's like this, I hate to say this, but there is this little ulterior motive, oh, we get access to 8 community health centers' data, right? No, you're not getting it. Not in this climate. I'm sorry. But, you know, it's all of these things. These are like very, very essential, critical, real issues that community health centers are facing. the social risk factor data, the project that I was talking about, I had this grand vision. I wanted like integrated system where everybody is doing everything that I told them to do and following every step that I asked them to do. No, none of it happens. You know why? Because now they're looking into EHR data. I don't want to highlight SOGI factors. I don't want to be looking at houselessness status, even though housing is medicine. I can't, because it is, now we are getting into that era of like where we are starting to look at personal health identifiers, and it's starting to go beyond, like, as healthcare providers, are we better stewards of data? So all of these are problems our health centers are trying to address, and as researchers, we also have to be mindful on what we can request, and access does not imply usage. So that is very critical, and keeping that in mind. So I don't have answers for you.
You just gave me like 10 different research topics. I don't know what you're thinking, but
yeah, if you can circumvent all the political and the regulatory environment, we are good. We can work together.
Yeah. Well, no, I think this is right, but I think again, from a scientific perspective, these are questions that ought to be answered. Let's separate that from will someone want me to do it? But these are questions.
This lets us get. This is the translation science, right? You are now really closing and narrowing the gap between policy, regulation, and clinical practice on what happens. Systems, structures, policy, and clinical practice all have to work in tandem. And right now, systems and policy and regulation, none of them are working for what is happening on the ground in the practice. What he's facing, what Shanell is facing, all of us are facing on the ground is completely disconnected from the systems and the infrastructures and the policies that we have overseeing it all, and we're not taking care of our communities because there are like barriers that we have instituted from top down that the bottom up cannot flow up. So this is the research question possibly that we should be asking, can we work on it together without disenfranchising the community partners, but connecting them all together?
Thank you. Roberto?
So just imagine if you lived in the Mission and you got evicted, and then you're living in a garage or in a car, RV, or a backyard, or overcrowding. And then COVID comes. You got another crisis. Well, and now, if you're an immigrant, now you got another crisis, right? And so currently, that's what we're facing in our community. And it's not just the Mission, because Latinos live in the whole city. And when we look at our immigrant brothers and sisters, right, having done a lot of immigration work, because a lot, if not all, except the Filipino brothers and sisters back in the days when I was with Cesar Chavez and Dolores Huerta in Delano, California, it was all majority Mexicano immigrants and Filipino workers. And I want to honor the Filipino workers because they never get recognized as part of that movement. And so when you look at currently, right, the immigrant members of our communities in San Francisco are, again, at the highest crisis. Can you imagine being an immigrant and the fear, depression, sadness, suicide, hopelessness? And thank you for acknowledging that the U.S. Supreme Court made such the worstest ruling that racist. And to me, that's criminal what they voted on. And it's like putting an end to democracy. I mean, it's like, that's it. So what we've done is that, and I led these, I've organized 30 immigrant families, and I've done 3 sessions. And I just did listening sessions and went around the room saying, how do you feel? What's going in your mind? What are you feeling? Let it out. And it was, again, just the learning from those 3 sessions helped guide us, right, of what we need to do in this moment, in this time, right? And I'm going to just give you one that was not part of these 90 different families that we worked with. There, I get a call, the first call that I got when this crisis arose. A father, head of household, worker, only earner, only the one that drives car, gets arrested by ICE on 16th and Mission, kidnapped randomly with 3 other people. The other 2 were U.S. citizens, by the way. He's from Peru. He gets no calls. 24 plus hours go by. He lands up in Arizona. Finally gets a call. Gets to make a call. Talks to the wife, and she panics, of course, because she's got the kids and they got no money for rent. They got no money for food. She don't drive. Doesn't know where the car's at. I mean, and you can just imagine the rest, you know. And then gets a call from him saying that they're going to transfer him to El Salvador. And you know what's in El Salvador. Another Guantanamo Bay, right? And so, can you imagine being that mom? It's criminal what's happening, right? So that's what we're having to deal with right now, right? And so there's a lot of work. So if any of you want to work, put some work in.
Thank you, Roberto.
Thank you.
Shanell?
Yes, very similar. Our communities, Black African American community in San Francisco, know the history of crisis, police violence, crisis, pandemic, COVID crisis. Now we're here looking at the destruction of our safety net. A lot of our folks that we serve the all generations. So we have a lot of seniors, everything from pre-conception up to seniors. So just really for us is thinking about the impact to the safety net and how we're going to have to meet that need, whether that be the food, other screenings and services. Really wanting to see how that is impacting our communities because it's coming. The cuts are coming down, and I've heard that they're not fully implementing the big ugly bill until after the midterms because they want to dupe folks into thinking, oh, there's no cuts that are coming, so they can still get those votes in the midterms. But it's coming. And so for us, it's like, how do we get prepared to respond and then also make an argument for what we do and what we've been doing in community and really evaluate that because it was said before, data and evaluation, it's not cheap. And we want to evaluate our programs, our model. That's the work that we're engaging in right now. Quality assurance, QI, QA, data evaluation. We know we need that because even locally, we have an administration that's like, we want to see the results. It's a whole shift. It's got to be data driven, got to show us the numbers. It's a different environment we're even in locally. So I would say really looking at the impact of this destruction of our safety net on our communities, and then also just, selfishly for Rafiki, we need support evaluating our programs and making a case for what we do so that we can pivot in this climate of, with this administration and the cuts that we're facing at multiple levels.
Thank you, Shanell. All right, questions from the audience? Raise your hand. Hey, hand over there. Make Saji walk over. If you have a question, also raise your hand. I'll keep an eye on. Anybody else?
A quarter away. Hi, I'm Marina Toulouse-Shams. I'm from our Psychiatry and Behavioral Sciences Department and know Dr. Lisa Fortuno well, so it was really wonderful to hear more about the project. And really just an incredible panel, and just really want to thank you all so much for all of your candor, your vulnerability. Really, and everything that you're doing. That speaks for itself for all of you. So one of the things in trying to raise above the black cloud a bit is I'm thinking about the power of discussion that's happening in this panel that Dr. Nguyen is facilitating, and wondering whether or not there is a community-led PI, because I'm not going to say non-traditional PI, I'm going to say PI, community-led PI network across the Bay Area in some way that can bring folks together in this space. Is that what's happening? Is there a network that we could also, for those of us who are actually co-investigators with our community, could actually know about and bring those folks together? And then the other thought I had was, within that network, has there ever been a conference or an opportunity where it is led by the community-led PIs and you're inviting researchers to come forth as your collaborators and co-investigators to foment during this time, to be generative and think through some of these thorny topics? So.
That's a great idea. Yeah, I think that's a great idea. I think the community engagement program has just got another idea to work on. I hate to put you guys on the spot about like one more thing for you to do, but that could be something we can think about.
Well, and if there's any way, because you highlighted mental health as a really big topic, so just putting it out there that our department would be very interested, I'm sure many departments, but just kind of wanted to highlight that.
Right, we'll take note.
Yeah.
I don't know of a community, and I thank you for that, the community-based PI, I love that language much better, network, but I know that over the years, sort of really advocating for community-engaged research, participatory action research, that we've seen a whole cadre of community folks get that training and get skills in study design and all the things. So I feel like, I know there's several cabs throughout UCSF, and folks are getting those skills in community research programs that have happened. So I think it's really about just starting that conversation, but I think that would be amazing to make that happen.
I have nothing to add, but like, yay, let's do it. I mean, that would be great.
Okay, ditto. Any other questions? Carrington?
Hi, this is Carrington again. I've participated in this a couple of times, and one of the things that has come up again and again has been the mental health piece. And while you were speaking, I Googled quickly barriers to people of color accessing mental health. And here are all these articles, and some of them written 10 years ago, but yet we still find ourselves at the same question: why are these barriers still there? And is that reflective of the disconnect between the research and the actual implementation?
We are creating a new model for community-based mental health. And our long-term vision, again, because one of the things that I want to just refer to something you talked about, is that throughout the years, we've seen a lot of research get done, and it just gets filed away, and it really doesn't cause change. And that's one of the things that, why we are real cautious and careful about who we partner with, because we want to make sure that the research is going to have policy change, structural change, and action. Because, yeah, there's tons of research out there that doesn't change. Nothing, absolutely nothing. And mental health is one of them. I mean, we know that, back in the 80s, I remember in the 90s with the African American community and the Asian community, was saying, hey, there's no culturally relevant mental health programs, in our communities. And that was addressed, and reports were made, and people got paid, but it didn't translate into nothing. And so that's, again, training people within the community to become those mental health workers, is the model that we're creating. And we're taking it not only to our Department of Public Health, but we're taking it to the state of California. because the state of California currently recognizes that there is a problem with mental health in the state. And so we're talking to legislators and the governor and saying, okay, you recognize it, now be partner and let's make the change happen.
Thank you. So we're at time, and first I want to please give them a round of applause. And please, thank you. I would just say that this is, from my perspective, what community engaged research is about, that we acknowledge the realities, we acknowledge the history and also the persistent oppression, and yet we all continue to persist. And you give me a lot of inspiration. Thank you very much.